Welcome to Advanced Patient Care, a podcast series by Vance Thompson Vision. Today's podcast is featuring Cataract Awareness Month. I'm your host, Spencer Morton, and this podcast is here to bring you the latest advancements, cutting-edge research, and practical tips that you can apply to your clinical practice right away. So if you're ready to expand your knowledge, stay ahead of the curve, and elevate your practice, you're in the right place. So I want to start off just by introducing our two panelists. I'm, as I said, your host, Spencer Morton. I'm the surgeon in our South Sioux City office in Nebraska. So I wanted to have each one of our panelists kind of introduce themselves with their name, what their role is, what location they are in, and maybe one fun fact about themselves. So as I said, I'm Spencer Morton, South Sioux City. I am an ophthalmologist doing cataract and glaucoma procedures. And the fun fact about me is that I really enjoy shooting archery, and particularly long distance archery, kind of stretching it out as far as I can do it and have it still be accurate. What about you two? Who wants to start? Sierra.
All right. My name is Sierra Steiner. I'm the optometrist here in Billings, Montana. I get the privilege of working with two surgeons where we do cataracts and glaucoma, corneal procedures, and refractive procedures. And my fun fact is I have 27 first cousins, and that is just on my mom's side.
Whoa. I have zero cousins on my mom's side. My
Wow.
mom is an only child of two only children. So I have just my mom and my grandma now and no one else on that side of the family. So that is a fun fact for me.
Wow. Well, I'm Lauren Swin. I'm the optometrist in Omaha, Nebraska. I work alongside Dr. Brandon Bartman, as well as Lori Preventure. And so we do cataract, refractive, cornea, and glaucoma. Fun fact about me is not super fun. I was born and raised in Lincoln, Nebraska. So I've been born and raised Cornhusker, basically. So that's my fun fact.
Love it. So as a little bit of a preview, in this episode, Dr. Steiner, Dr. Wynn, and I are going to be talking about Cataract Awareness Month. So we've got a couple of talking points just to preview. The first one is kind of patient experience and patient education. We'll get input from Dr. Steiner and Dr. Wynn and myself on some of our pearls and some of the things that we do at Vance Thompson Vision that it might be a little different. Then we'll talk about optimizing outcomes through collaborative care and some of the pre-op, post-op, how ophthalmology and optometry interface and work together. And the third is the future of cataract surgery, just kind of some of the things that we are anticipating and excited about moving forward. So I think we will start with episode 1 leading in here, kind of the patient experience and patient education, talking a little bit about lens discussions, and then again, we'll touch on a little bit of our See and Do program, and again, our back-to-back program. So, we here at Vance Thompson Vision, we recognize that people can go anywhere that they choose for their cataract surgery. And most people in this country live in locations where they have choices, where they have to decide what doctor or what group they would like to see and trust their eyesight with. And typically people end up with a why for why they choose where they go. And, I think a big part of that has to do with reputation of physicians and organizations, as well as, word of mouth. I can't remember the last time that I went and tried a new restaurant because I saw a commercial. It's always because I have a friend or a neighbor or a family member who say, hey, you've got to go try this place out. The food is awesome. And that always carries way more weight than something that you see in print that's put in front of your face. And so I think in order to achieve those things, the things that I always think about is striving for a patient experience that is second to none, where I think we should be able to look ourselves in the mirror at the end of every day and say, patients who come and see us not only feel valued, but know that they're truly cared for, and that the honor is truly ours, not theirs, to see us. I think that we have to have the gratitude as care providers that we are the ones being blessed by the patient, not the other way around. And so I think the way that we can achieve this too through having an experience second to none is by having, the world's best technology and finding ways to suit that technology to the patient's needs, not the other way around, not making the patient's needs fit the technology that we have. And so I think, an experience second to none and outcomes second to none. And our job is to try to achieve both. And so that's kind of how I approach the patient experience. And so getting into the patient education side of things, I'd like to start kind of with some lens discussions. So when we have patients that show up in front of us, they've already met with their optometrist, they're diagnosed with cataracts, they know that they need to have a surgery, and they know that they're going to have a decision to make as far, well, maybe they don't know that they're going to have a decision to make, but they're going to have a decision to make as far as what lens do they want put in their eye, and what do they want that lens to do. And before we can really talk about which lens the patient gets, we have to kind of determine what candidacy they have. Not every patient that walks through our doors is a candidate for every lens that we have available, or is necessarily a good fit for every lens that we have available. So I think that I'll start by asking Dr. Steiner here, what are some of the pre-op tests that you're looking at prior to meeting with the patient and that help you kind of determine the candidacy for certain lens options? And what other factors are you considering when you're deciding who may benefit or not benefit from certain lens choices?
Yeah, we do, I think probably amongst the different Vance Thompson clinics, most of our testing is pretty consistent, but some of the machines will probably look a little different from one location to the next. We always get a corneal scan. We always get a biometry measurement. We always do some sort of back of the eye measurement. So like a macula nerve OCT. On some patients, we get an optos photo as well. Our technicians are incredible at getting those tests in a timely, efficient manner, also explaining to the patient what the test means, which is not an easy feat because it's a lot of tests and a cataract evaluation can take a little while. But our technicians do a really, really good job at gathering all that stuff, making sure we have good quality scans, making sure we have all the information we need in order to be able to match the technology to the patient. So from a workup standpoint, that's kind of what we start with. And then, evaluating all of that stuff to make sure if we're recommending a lens that again, that technology will fit to what their wants and needs might be. And so preoperative workup is important. And then probably just as important or more importantly would be just understanding what the patient wants out of it. So getting to know the patient a little bit during the conversation of how do they use their eyes, how much do they want to wear glasses or not wear glasses afterwards, and then taking all of that stuff into account to make the recommendation and finding that right lens for the patient.
Yeah, Dr. Nguyen, anything that you would add to that?
Yeah, I think also just, ocular history, if they're post-refractive, sometimes we'll grab additional scans like a epithelial thickness map. If especially it's hard to discern if it's a myopic or hyperopic ablation. Glaucoma patients, sometimes we'll go ahead, grab a visual field or a corneal hysteresis, those things too. And definitely, I think the most important aspect is just getting to know the patient. We only have a very short or limited time to discuss and talk to them. And so what's really valuable too, I think, is just the referral notes, just the preoperative notes that we get, because oftentimes there will be a doctor that writes, this patient's very particular, probably is not going to be a good candidate for a multifocal. I might have to pull my hairs out if we do decide a multifocal is going to be the way to go. Or they say, they think they're a good candidate for like a light adjustable lens or something. And so I do think that those notes that are added in the pre-ops are very helpful for us because it gives us more information to go off of.
Yeah, I think to piggyback on that a little bit, sometimes the specifics of the refractive target is really helpful too. There's a section in our referral note that says what's your desired refractive outcome. And if you get a referral note that just says monovision, it's really hard to know, okay, well, which eye is their near eye, which eye is their distance eye, how much anisometropia have they been able to tolerate in the past, how near is their near eye, and a little bit more background is great, especially if you are seeing a patient as a C&do candidate, and you kind of need to know that stuff right away. The other thing that I wanted to circle back on, after agreeing with you, Dr. Wynn, that the referral notes are critical, is how Dr. Steiner had mentioned, oh, and we do a scan of the optic nerve. And some people immediately are like, why are you scanning the optic nerve? I don't have glaucoma. And, I always tell patients glaucoma it can be sneaky. And if you aren't looking for it, you will never find it. And there are oftentimes patients who can sneak through the cracks or be a little bit tricky with their glaucoma diagnosis. And so I think I personally here we get a optic nerve OCT and retinal nerve fiber layer on every cataract evaluation that we do. And it's not because I think everyone has glaucoma, but it is because I think if someone has glaucoma and they come here and I do an intraocular surgery on them and I didn't address their glaucoma or at least give them an opportunity to have it treated, I've done that patient a disservice. And even if I diagnose glaucoma, tell them that they have it, offer a glaucoma procedure at the same time of surgery, and they say, I don't want that, at least they know that they have glaucoma and they're better educated and they leave better served knowing their diagnosis and knowing the things that they need to be looking out for in the future. Anyone else have anything else to add before I move on to the next question?
Yeah, the only other thing I would add in terms of like the preoperative notes or the notes from the referring doctor is any history of prism in the glasses is really helpful and important, because that can be an easy one to miss if it's not a large amount of prism. And the last thing we want to do is put a multifocal lens or an upgraded lens in a patient to get them out of glasses, only for them to be reliant on prism afterwards.
Yes, we've actually had 2 patients now that have shown up with a history of prism and ocular misalignment, and when they were told that they were not a candidate for a premium lens or a multifocal lens because they would still need glasses afterward, we've had 2 patients abort their cataract surgery and instead have strabismus surgery and come back after their strabismus surgery and then have multifocal lenses in and do well. That's a pretty long course, but when people are quite committed, you can still do well with that kind of thing. So I want to move on. The great discussion there, but another big part of, I think, of kind of what we want to achieve to draw people here in particular is we want to be the easiest practice to work with, and we want to be the easiest, most efficient thing for patients to do. And living in the upper and mid Mountain West between Nebraska and Montana here, we do have patients that travel quite a ways, and so we try to minimize the number of trips that they need to come and minimize the amount of time that they're kind of down and out after surgery. And so part of the way that we do that is by our see and do and same day, next day surgery process. And so for people that aren't familiar with that, we are when we're talking about a see and do, we have some front end planning and coordinating that occurs, and then we have a day where we meet the patient and perform surgery on their first eye on the same day, and then we do their second eye the next day. And we also do same day, next day surgery for people that aren't see and do. If they come in for a traditional cataract evaluation, but they decide, I think I want to just do both of these surgeries back to back, we accommodate that for people so that working professionals, people that live far away that want to get on with life and back to action, it helps them do that faster than waiting a week between eyes. So Dr. Wynn, what are the biggest benefits that you've seen for patients that are electing to do the see and do process, and who do you think are the best candidates for this?
I think definitely just working in the Midwest. I mean, there's going to be people that live many, many hours away. And so just giving them the opportunity to not have to make multiple trips back and forth, and just giving them the convenience and ease of mind that they can have this surgery done as quick as possible, like you said, in a timely manner. I think that's going to be kind of key, is just the drive if they don't have drivers. We try to make it easier too by working with, partnering or nearby hotels just to see if they want to stay there versus with family members if they have any nearby. I think that's going to be another key thing. In terms of like who would be like a good candidate, I mean, as long as the referring doctor thinks that they have the information at hand and they can make a decision, I think that's always key. Sometimes there's going to be some patients that need maybe a little bit more time or hand holding. Sometimes they may not be a good candidate just because if they can't make that decision prior or need more information from the doctor itself, sometimes they won't be the ones that will make the decision on the day of their surgery, especially if there's a lot of anxiety or nervousness. So.
Yeah, I think that's some really good points there. And I think, Dr. Steiner, perhaps you could touch in here. Perhaps one of the most important aspects of this discussion is the pertinent negatives. So, who are some of the patients that are not good candidates for a see and do? Because I know that there have been times where we have certain referring docs that just every single referral checks off the see and do if possible, see and do if possible. And I think that it's valuable for people saying, well, who's appropriate to send for a see and do? Is it just that the patient says they want it, or are there times where I shouldn't be doing this? What are some of the instances where you think, man, I think this would be better as a regular referral or regular evaluation?
Yeah, I would say probably the patient that lives 2 blocks down the street is not ideal, mostly just because we try to reserve them for the patients traveling long distances, and we make exceptions to that, of course. But generally, if they can get here easily, we do it in 2 separate visits. A really complex ocular history can be one where we would just say, let's do the evaluation first and then, make a plan for surgery and schedule it at a later date. Really nearsighted or really farsighted patients sometimes will be tricky, and we catch those sometimes on the see and do preoperative calls. We always try to call those patients about a week ahead of time. And so sometimes they've already been scheduled. And as I'm reading through the pre-op note, I see that they're a -12. And so generally we'll still keep them on the schedule as a see and do, but just with the understanding that, hey, we might not have the lens power that you need in stock, especially for every lens implant option. And so if that's the case, then we may postpone it, order that lens and postpone it. Those would be the big ones. I'm sure I missed a few, so you guys chime in.
So I think the thing to add on to that, Dr. Steiner, is anytime where I'm seeing a patient and I'm looking at them and I say, boy, even with great surgery, there's going to be corneal edema here. So if you've got a patient with a really dense lens, a really narrow anterior chamber, Fuchs, things where a bad pseudoexfoliation, as you had mentioned, those are instances where I'm sitting there saying, okay, if everything else checks the box, this is that 90-year-old lady who lives 2 hours away who wants to come in only one time, but she has brown lenses in both eyes and a narrow anterior chamber. And if we do excellent cataract surgery on back-to-back days, she's still going to have corneal edema in both eyes. And what I don't want is this 90-year-old lady to fall down the stairs a day after surgery because she couldn't see well, right? So I think that as much as we want to help as many people as we can, it does have to be with some diligence there. The last thing I would touch on is probably, bad glaucoma patients that may need an extensive glaucoma procedure that could cause a hyphema or meaningful vision change after their glaucoma procedure. And lastly, people who have uncontrolled dry eye, because it's really, really difficult when you're meeting a patient for the first time, planning to do their surgery an hour later, and their cornea looks like a track meet has just been held on it. And, you're trying to get high quality preoperative measurements that will dictate the quality of your outcome. And if you have, garbage in, you're going to get garbage out. And so I think if you have a patient that really wants advanced technology lenses, but again, has that terrible looking cornea, you're not going to get good scans. And it can get tricky because there's inertia to do the surgery because they're there, they took time off work, they're there to have their surgery, but you have to make sure that it's someone whose ocular surface is amenable to doing a surgery on the day of. But before we move on to episode 2, optimizing outcomes through collaborative care, Dr. Wynn, do you have anything else to add?
Oh, I was gonna say too, patients that have had recent retinal surgery, if they've had any sort of like silicone or oil in the eye, and it's gonna obscure the biometry, I mean, that's definitely something we want to wait until the retinal specialist has been able to take that bubble out just to make the scans more accurate.
Yeah, that's a
Sometimes the surgery before with a bubble, that's pretty minimal, but probably want to hold off on that one.
Yeah, I think that the timing and tempo of when you pursue surgery is important after already having had one surgery. So
So
I think go ahead.
previous RK patients can be really tricky for a see and do as well, just because they require so much conversation, and generally having at least a couple sets of measurements on them is helpful. And
Yeah.
so that's another one that it's not a hard rule for us, but we usually try to talk them into doing it in separate visits.
Yeah, I think any kind of previous refractive surgery, especially incisional refractive surgery, warrants at least an orange flag of a pause and let's make sure that this is someone that absolutely needs this, and then you pursue. Let's move on to episode 2 here, which is optimizing outcomes through collaborative care, kind of some post-op review stuff. I happen to believe that eye care is probably the best example or one of the best example in all of medicine, how collaborative care can function at its highest possible level. If we have, both ophthalmology and optometry pulling the same rope in the same direction. One of my mentors always said ophthalmology and optometry are two sides of the same coin. And in order for our patients to have the very best experience and best outcome, both sides of the coin have to be at the very top of our game. There's got to be really good, primary care and optometric community and good diagnostic and referral capabilities. And there's got to be really good, excellent, efficient, elegant surgery that's done when it's needed. In my opinion, I actually believe that, and I doubt that I'm alone, that optimizing outcomes actually starts way before the surgery even occurs. I think that, as we had touched on in episode 1, ensuring that our patients are showing up as tuned up as possible is the best way to get a jump start, a leg up on getting great outcomes. I think if you have a patient that shows up with a pristine ocular surface and a really good educational foundation of, I'm going to have to make a choice on my lenses. I know I'm going to have some options and a rough outline of what those options are. It's super, super helpful for both the patient and for the surgical team of our optometrists and ophthalmologists. So I'll start with, again, Dr. Steiner. What are some of the best ways that our referring colleagues can help ensure that the patient is set up for success even prior to arrival at our offices?
Yeah, I think you're right. I think we already touched a little bit on some of this stuff, but first and foremost, having the talk and the conversation with the patients that probably they've had a long history of knowing. So, what are your goals? And then sharing those with us. So to your point, if it's going to be monovision, how much monovision, which eye's distance, which eye's near, how long have they done it in contacts? Has there been any struggles with monovision? So any details pertaining to that is really helpful. Ocular surface is so important. And even if the patients have already started a dry eye regimen, the education about the differences between dry eye symptoms and cataract symptoms is also super important, because every single patient comes in and says, well, my vision's blurry and that's why I'm here. And trying to get to the root of why is the vision blurry and sorting out what's cataract and what's dry eye. And we, when I talk with patients during their evaluation, we try to sort that out, but just as long as they know your eyes are dry, you've had a history of dryness, it's being treated, but you're still going to have some of that afterwards that can create some symptoms. I think as long as those conversations are happening ahead of time, it's less frustrating on the back end.
Yeah.
Those would be the two big ones.
Dr. Nguyen, what do you got?
I think too, with like patients that are suspicious for glaucoma or even managing them for a while, just having that additional information ahead of time, but then also making sure that they're on a management if you think that they're going to be a good candidate for a mixed procedure. Sometimes insurance does need to see that there have been previous treatments in place ahead of time before you do that, versus having them come in thinking maybe they might be a good candidate, but not starting them on a job sometimes can make it difficult for us too.
Yeah, and I think that you're both right on the money. I think the other thing would be setting the table. I mean, it doesn't require a 45-minute conversation, but I think setting the table for expectations and limitations of certain technology and options. I mean, I know that we've all seen patients come through and they're like, well, I don't know why I need to have an astigmatism correcting lens because my neighbor had surgery and they don't need glasses and they did the one that insurance pays for. So that's the one that I want. It's tricky because that patient is sitting in front of you with 3 diopters of astigmatism and a lamellar macular hole. And that's the way it always works. And so I think that education on the front end can help save chair time for both referring doctors and us on the back end. I think if you're sitting in clinic and you have a tablet up or a laptop up or a printout of a macula OCT, if you have one in your clinic, and showing them, hey, you have this thing called an epiretinal membrane. It's starting to distort your, the anatomy of your retina, and that's going to affect how you see. And even with a excellent cataract surgery, this is still going to be here. And so you might notice after surgery, my right eye is not quite as good as my left eye, and that's okay. I think a patient knowing that going in is way better for them on the back end. It also does a lot for, I believe, patient trust in the referring doctor as well, because there are often times where I'll get a referral note that says, patient has epiretinal membrane in the left eye. I do believe it's limiting vision. Just know that going into surgery. And then we talk to the patient and say, well, you have this epiretinal membrane in the left eye. And there's a, well, Dr. So-and-so never told me about that. Why didn't they see it? And I'm like, they did see it. I know that they saw it. And it's just a communication issue. And if they're told that on the front end, and then it's confirmed and also discussed when we talk to them, they're sitting there saying, yeah, I knew that. And, my optometrist is really good because they already told me about all that stuff and I know what I'm dealing with here. And so I think that it both helps prepare the patient and also strengthens relationships with, patient and referring doctor to have some of those discussions ahead of time. And then I think that as far as the the ocular surface thing and the previous refractive surgery monovision things, I think, as you had said, tuning them up as much as you possibly can from an ocular surface standpoint only helps us. Knowing if they've tried monofocal contact lenses and tolerated it well is super helpful for us. And then knowing if they have had previous refractive surgery, letting us know what it was and how they did with that only helps us on the back end. So that's mostly before surgery stuff. What about as far as after surgery? Dr. Nguyen, what do you think are the biggest keys to the post-operative management to help kind of ensure that our patients are extracting as much benefit from these surgeries as they possibly can?
I mean, we said it preoperatively, optimizing the ocular surface. I think that still carries forward even in the postoperative care too. And so, especially during the first 4 to 6 hours, I usually say it's going to be super irritated, scratchy. A lot of folks may not anticipate that. And so letting them know ahead of time, but then also saying, hey, these lubricating drops are here for you for a reason. Use them as often as you need to. I think that really helps letting them know too, just like what their vision's going to look like afterwards, especially if we anticipate there is going to be some edema if they have a denser cataract. Letting them know, hey, it's going to be fuzzy for a while, but as long as we continue to use these medicated drops, that's going to really help. It'll take more time compared to, Bobby over there, but it's going to get better for you. I
Sure.
think those are key things, is just kind of telling them what to anticipate during the care. I think will optimize things for them.
Yeah. What about you, Dr. Steiner?
Yeah, I agree. I mean, I think you can't probably overeducate a patient. So, if there's probably two different ways to look at it. If they're standard lenses where we know they're going to need glasses after, than just a little bit of hand holding between the time they had surgery to when they need the glasses, to explain, here you're not at your optimum vision yet because you don't have the updated glasses to see where things are going to be when you get them. And then, I think a little bit different path or route if it's a premium lens and we're, trying to get them out of glasses. If we're a little bit off target, then just making sure those patients are getting back to us in a timely manner. Lots of conversations in the meantime about, hey, there's maybe a little bit of residual astigmatism. We'll touch that up, but there's a bit of a wait period until we want to do that. We have to let things stabilize first.
Yeah, I think you're right on the money too with having it be difficult to overeducate somebody. I think that there are patients that will kind of start to cut you off when they're like not interested anymore in hearing more details. But I think I would way rather overeducate people, and I would also way rather undersell and overdeliver. I think I would way rather promise less, thinking that we're going to deliver more, than the opposite, and having people's expectations align closer with reality. I think that's how you end up with people who are happier and do better. Well, let's move on to episode 3, which is the future of cataract surgery, which is kind of exciting. I think that we would probably all agree that cataract surgery is a really exciting field to be involved in as a care provider. I think it's a great time to be someone who is involved in someone's cataract surgery journey, just because of the technology that we have access to now that we previously did not. If somebody came in 30 years ago and they said, I want to have my cataract surgery and I want to see far away and I want to see up close and I want to see in the middle and I don't want to wear glasses for any of that stuff, they would have been like laughed out of the office and been like, well, that sounds cool. We can't do that. But we're in a time now where we can look those people right now and say, yeah, I got you. We can do that. We have the technology. We can do this. And so I love it because we have made advancements to the point where such a high percentage of our patients are really happy, even the ones who are pursuing, advanced technology or spectacle independence after a cataract surgery. And I think that the tempo with which the technology is advancing makes it even more exciting, both with cataract and glaucoma procedures. I think I'll just start out by saying maybe what I'm most excited about is kind of the continued pursuit of the holy grail of intraocular lenses, which I tend to think is a truly accommodating lens. I know there's been pseudo accommodating lenses and things like the crystal lens and things that haven't quite panned out the way that we had hoped that they would. But there's a lot of really exciting research that's been going on recently about accommodating lenses, and some of those are multi-lens systems with there are fluid-filled reservoirs that are using ciliary body to change lens positions within the eye, and even some lenses that are being studied that have a PCO rate of 0, which is pretty cool. And so I think that the thing that excites me the most is the pursuit of the Holy Grail with accommodating IOLs, and then just improvements in both diagnostic and surgical equipment. I think that as time continues to march on, we will have access to better phaco machines that are more efficient, that deliver less ultrasonic energy, have less corneal edema, have more efficient surgery, and create more capable surgeons and happier patients afterwards. So I guess this will be maybe less directed to one or the other of you, but just if either of you have anything that you're most excited about for kind of the future of intraocular lenses specifically, and if not that, just kind of the whole cataract surgery field in general.
I think for just advanced implants, similar to like what you're saying too, I mean, an accommodating IOL would be fantastic. Something that can just replace the natural lens and still function in the same manner would be awesome. Or even just like a multifocal that has less dysphotopsia. I mean, with the multifocal technology we have now, it's really, really good too. I mean, that's one thing that we should highlight as well, as the multifocals are doing a really, really good job. But at the same time, the dysphotopsia, the glare and the halos are probably the hardest part for folks as they transition and get used to that implant and the neural adaptation. But yeah, I mean, I'm hopeful that by the time I need cataract surgery, that it'll be something that works just as well as my natural lens.
Yeah, one of the conversations that I always have with patients is, these lenses are amazing. The technology has come such a long way. They're not the same as our God-given lens, and we'll probably never have that, but man, just getting closer and closer to that is exciting. The other piece is, to your point, Spencer, the technology changes, I think, will continue to make our jobs easier and easier. And as I'm talking with patients about lens implant options, they kind of sit there and often go, man, I just wish I could try them out. I just wish I could test drive this one compared to this one. And so, there's some emerging technologies. This is maybe a shout out to Green Man, but that will get us to a point where, the patient can actually put a headset on and walk or, experience what it would be like to live with one lens versus the other. And I think that's really valuable for the patient to get to try ahead of time.
Yeah, I think it's even valuable too if you've ever tried the Green Man headset on. So for folks that don't know, it is a virtual or augmented reality headset where patients are able to be shown different lens options and what their vision will look like at distance, intermediate, near, bright light, dim light, halos around lights, and it's an interactive scenario where you can pick up a cookbook and look at it, or sit in your car and look around and see what headlamps and streetlights look like. That's amazing technology. But I think that part of the value of that will not only be showing them, wow, here's what a multifocal looks like, but also, again, kind of pertinent negatives. So you take the person who's trying to decide between a multifocal or a standard lens, and you just show them absolute presbyopia, and someone who's not used to that, or maybe has just the littlest bit of accommodative reserve left over, and you show them absolute presbyopia even without a cataract, and a lot of people who put that headset on are like, oh, this isn't quite what I was hoping for, or I may need to wear trifocals for the first time in my life. And I think just showing people the closer and closer that we can get to a realistic expectation with a trial, I think only benefits patients and then providers as well. I think one of the things I would add as far as things that I'm excited for, with every couple of years, we have newer and newer generations of intraocular lens equations as well. And so having the data that we have gathered, the better the equations are, the closer that we get to perfection every time. And I think I view it as getting a bigger and bigger and bigger bullseye. I think the bigger we can make the bullseye, and the more accurate we can be with kind of our shot, the happier patients that we're going to have. And I think both, newer generation equations and more accurate diagnostic testing. And we've seen even in our young careers, the evolution of even people that are post refractive, right? If you had a person that was a prior LASIK patient or a prior RK patient, you used to have to manually do a whole bunch of stuff on the ASCRS website, and you were like a miniature Albert Einstein trying to figure out what lens this person needed after their myopic ablation that was 10 years ago. And now we have things like Barrett True-K and Aura and light adjustable lenses, where again all those things are making the bullseye bigger for patients that might otherwise have been a more tightly thread needle. So I think that those are the things that I'm probably most jacked about. Is there anything we haven't already discussed that either one of you guys want to touch on?
I think segueing away from just implants, I think it would be awesome to get to a point where we don't have to provide post-operative drops for patients, just be dropless completely. The one thing I always hear after their surgery is, man, those drops sting, especially the ones that we get through Imprimis, the combo drops. I mean, we've gotten to the point now where we can do one drop a day for 30 days, but man, it would be awesome to get to a point too where all patients are a good candidate to not need that and do something during surgery.
Yeah, I think you just reminded me of something else too. I think another thing I'm excited for, which I believe will be a reality in the next 10 years, is immediately sequential bilateral surgery as well. I think that with the way that it's set up right now, at least how my brain organizes it, the likelihood of getting bilateral endophthalmitis is like getting struck by lightning twice in the same storm. It's not super likely. And I think that once insurance companies realize that they'll have to pay a facility fee once, pay anesthesia once, do all this stuff, that it's cheaper and way better for a patient. Again, like we had the discussion with the same day, next day, not for everybody. Not everybody's going to be an immediately sequential, surgery candidate. But I believe that we will be doing immediately sequential surgery for good candidates for sure in our career, but hopefully in the next 10 years or so. And I think that's another step in providing a better experience for well-informed patients that are looking for a quicker in and out, quicker back to regular life. So I think that that's probably going to be a wrap on episode 3. And just want to thank you guys for all joining us for our Cataract Awareness Month chat. If you want more, you can schedule your personalized mini fellowship at Vance Thompson Vision today. Immerse yourself in hands-on learning, gain insights from our experts, and take the next step towards excellence in eye care. Remember, the world of eye care is ever evolving, and so are we. And until next time, this is Spencer Morton signing off. And don't forget to visit our website or follow us on social media for additional resources and updates. Thank you guys so much, and I hope this was helpful. And Dr. Nguyen and Dr. Steiner, thank you both for your amazing insights. And I look up to you guys, and I thank you for joining us, and have a good one.
See you guys.
Thank you.